So there is no competition between them, and that is why this is non-competitive. Also, one very important thing is the therapeutic index. But first, to understand what is it, we will discuss the effective and lethal dose. Effective dose, ED50, this is the dose at which 50% of population shows the response on the drug. For example, paracetamol effective dose is 50 milligrams, 500 milligrams, so 0.5 grams. This is effective dose. Actually, it's not an effective dose. I'm telling you not the truth, but it's like, for example, just for example, and in which 50% of population show the response. But we also have lethal dose. Lethal dose, that means a dose at which 50% of population dies. So if we, for example, overdose 10 times and give 5 grams of paracetamol, then 50% of population maybe will die. So this is lethal dose. It is only example, guys. It is not the true numbers. So what is it? Therapeutic index. Therapeutic index actually is an indication of safety of the drug, which shows us the ratio between lethal dose and effective dose. The higher therapeutic index is, the better drug is. So you see that if the lethal dose is much more than effective dose, it means that this is a low risk of overdosing, the low risk of dying because of this drug. But if the lethal dose is close to effective dose, this is very bad because it is dangerous and we can overdose easily. So here we show this. What can we see in our therapeutic index? If the effect of the drug in the dose, in the effective dose is somewhere here, and the lethal effect of the drug is here. So this margin of safety shows us from where to where, which numbers we can administrate to the patient to be sure that he will be safe, he or she. And if you administrate the drugs only here in this margin of safety, then you can be sure that your patients will not die because of overdosing and having the lethal dose of the drug. So we always want to administrate the drugs which have big margin of safety, because the more these numbers are, the safer our patient is. Let's talk about tolerance, desensitization. This is decreased response to same dose with repeated exposure. Or maybe more drugs should be needed to achieve the same effect. How it happens? For example, today I take 1 tablet of phenobarbital, and tomorrow I take 1 tablet and I sleep well because of that, because this is a sleeping pill, yes? And I sleep well, but after 2 weeks of taking phenobarbital every day, I feel that it doesn't work anymore, and I need to increase dose to achieve the same effect. Yes, so my body doesn't already feel this dose of the drug. I need to increase it. So this means that I have tolerance to phenobarbital. It can be also developed across drugs, like I'm taking phenobarbital, but also I have the same effect with ethylenol sodium. So if the structure of the drugs is similar, by taking one drug, you can be already tolerant to another drug because they have chemical structure very similar. How this effect is caused? This can be caused by compensatory mechanisms that oppose the effect of the drug. So our body fights with the effect of the drug, and by the time this effect decreases, so the more time, for example, nicotine, yes, is shown here. Some people who smoke a lot, they start with 1 cigarette a day, then go 2 cigarettes a day, 3, and so on, and then a pack a day they smoke, because 2 cigarettes a day is not enough for them already, because they have tolerance to nicotine. So a pack a day, now they have to smoke. And also we have opposite effect. We have sensitization. Sensitization is opposite. It is increased response to the same dose with repeated exposure, or less drug can be needed to achieve the same effect. It can also develop across the drugs, but here it is actually the opposite effect. It is possible to develop tolerance to some side effects and sensitization to other side effects of the same drug. For example, if we use cocaine and we use that during some time, so seizure induction can increase by the time. Firstly, you take the dose of cocaine, which doesn't give you this effect like seizures, contraction of skeletal muscle, yes, seizures. But tomorrow you take the same dose of cocaine and already you have this side effect. And this is a very frightening thing because you didn't expect, because you took the same dose, yes, but suddenly the seizures appeared. So it can be the result of sensitization of your body to this drug. Okay, what can be the mechanisms of tolerance or sensitization? It can be the result of pharmacokinetics, maybe changing in the drug availability at the site of action. Decreased bioavailability of the drug, so less drug is absorbed, maybe firstly your body absorbed the drug, but then it stops. It can be also increased binding to depot sites. We have the deposition of the drug in our body, for example, in fat. In our fat, some drugs can be, like, they can store, they are stored in the fat. And also pharmacodynamic reasons can be, for example, changes in drug receptor interaction, G protein uncoupling, downregulation of receptors, the change in number of receptors due to changes in stimulation. The more you stimulate some receptors, the less receptors you have, because they don't want to be stimulated so much, yes? So like this, like your body protects itself from this extra stimulation. And also it can be metabolic. The user is able to break down or excrete the drug more quickly due to repeated exposure. So your body, for example, your liver can work more actively for metabolizing the drug and then excreting that from the body. That is why it affects less. And excretion can be also increased by your kidneys, for example. Yes. What can also be? Also, we can have some cumulative effect of the drug. When you administrate the same drug in normal situation happens what? Low effect to high effect. When you give the same dose, firstly it affects good, but after some time it decreases. Then you give again the same dose, again the same effect, the same. But some drugs, they may produce effects that are more pronounced than those produced by the first dose. You see, firstly you have one effect, but on the second day you have already more effect, and more and more and more. Why that happens? Because of accumulation of the drug, cumulative effect, accumulation of the drug in the body, for example, in those depot sites, deposition of the drug, yes, or binding to some proteins of your body. So this will give you this increased effect. What else? Also, we have additive synergic effects. This is already about two different drugs, drug A and drug B, for example. Yes, if I give drug A of like two chemicals, yes, two chemicals which have some effects, for example, increase in heart rate. Yes, drug A increases heart rate for 5 beats per minute, and drug B also for 5 beats per minute. And when I give them together, they give me 10 beats per minute, for example. Yes, it's just an example. And if this effect of two chemicals is equal to the sum of the effect of two chemicals, then taken separately, then we call it additive synergic effects. I will show you here now once again for you to see that if here we have, for example, 5 beats per minute in drug A, And in drug B, we have also 5 beats per minute. And when we use them two together, we have 10 beats per minute. If such situation is observed, 5 plus 5 will be 10, then we call it a additive synergic effect. Okay, but this is not the only synergism that can be seen. Synergism, that means synergic, they help each other, yes, synergism. What can also be here? We can have potentiative synergic effect. Potentiative, what does it mean? Here you can see, yes, if it was 5 and 5, but together it gives not 10 but 20, for example, 20. That means they increase the effect of each other. The effect of two chemicals taken together is greater than the sum of their separate effect in the same doses. Example can be alcohol and other drugs with effecting on CNS. If you are taking some sedative drugs separately or alcohol separately, it can be not very dangerous. But if you mix sedative drug with alcohol, your CNS can stop. Like that, effect like that. So it can be very, very strong effect, and it can be very dangerous, okay? And we have also opposite situation, the antagonistic effect. Antagonistic, it means that two drugs that don't help each other, and the effect of two chemicals taken together is less than sum of their separate effects at same doses. So it can be like this, that 5 plus 5 will be not 10 but 5, or it even can be 0 here if they, for example, stop each other, yes, completely just stop the effect and nothing will be. So maybe it can be just 0 here, and this we call antagonism, antagonistic effects, because they stop each other, anti. Okay, this was the main principles of pharmacodynamics of the drugs, and now we go to pharmacokinetics. Pharmacokinetics, this is science which studies how the body affects the drug. And there are 4 stages of the life cycle of the drug in our body. First is absorption. Absorption, it's the first, what happens, for example, in our GIT. Yes, GIT from the small intestine predominantly, the drug is absorbed, but not only there. And then distribution of the drug, how it distributes in our body, in which organs we have the deposition of the drug, in which organs it can affect, where, how much drug will be found in our blood, and so on. So how it distributes. Then degradation of the drug. Degradation is actually biochemical metabolism, because our body can affect on the molecule of the drug. It can our body can make oxidation. Our body can make opposite to oxidation, reduction. Нет, не reduction. Да, reduction. Well, our body can make different biochemical reactions, because you know that we have many enzymes which can work with the drug. So this is degradation. And then excretion. Excretion, you understand that it can be when the drug is like goes out from our body. Yes, it can go out by stools, by urine, by exhaled air, and so on. So the body gets rid of the drug. This is excretion. And all these processes are studied by pharmacokinetics. Pharmacokinetics of the drug. How fast the drug goes out, how much percent of the drug will be absorbed. This is all pharmacokinetics. Okay, and about the pharmacokinetics, what can affect the life cycle of the drug? First is the route of drug administration. The most popular is orally, which can be swallowed. Yes, tablets, capsules, different solutions which we swallow. Then, also it can be through mucous membranes, through the oral mucosa, sublingual tablets, yes, you know, and maybe nasal mucosa. When the drug is inhaled through the nose. And here you can see the cocaine. Some young people use this cocaine by nasal mucosa administration. And also we have some topical transdermal administration. Here you can see the example of this plaster, not plaster, what is it? Not plaster, which we put on our skin, and through it the drug can absorb to the blood. And also rectally can be administered in the form of suppositories, which we put rectally. Okay. Oral administration. As I said, this is the most popular. Why? Because it is relatively safe, doesn't injure the body membranes or skin. It is economical. You don't have to spend extra money on syringe or something. It is practical because it is easy. The patient can just take without any special help. But disadvantages: blood levels are difficult to predict due to multiple factors and limit absorption. Multiple factors what? When the drug, when you swallow it orally, it goes to the stomach, and in the stomach you have what? Acid, some enzymes, and this digestion, everything can affect the drug. Some drugs are destroyed in stomach acids. Yes, some drugs irritate the gastrointestinal system. So we have some disadvantages of this administration. Faster absorption can be we can get if we administer it parenterally, for example, by injection. Intravenous injection, intramuscular injection, and subcutaneous injections are the most popular. This is the intravenous injection, when you directly give the drug in the blood. This is the quickest, the fastest absorption. How to say it, absorption? Even we don't have to absorb because drug directly goes to the blood. This is intramuscular administration, in which the drug goes to the muscle and from the muscle absorbs to the blood. And this is subcutaneous, when the drug also can be absorbed to the blood. Also, faster will be if you inhale the drug through the lungs. For example, for anesthesia. You know, in surgery, yes, general anesthesia is given when the patient can inhale this anesthetic drug, and he falls asleep in just 10 seconds, sometimes, yes, 1 minute. So this is a very quick absorption. And also some drugs can be inhaled by this like aerosol, yes, for bronchial asthma treatment, for example. So you also don't have time for absorption. You want something very, very quick. So you can inhale the drug directly to the lungs. The fastest variants. For example, if you want to affect the brain, you can deliver the drug directly into the brain, intracerebral or cerebroventricular, intrabrain ventricles, or brain tissue. Actually, I don't actually think that this is a very popular type of administration, but maybe sometimes in the hospitals, yes. And what is the general principles of this? The faster the absorption is, the quicker is the onset, and the higher is the onset, but the shorter is the duration of action. So you give quickly the drug, it quickly affects, but not for the long time. Because, for example, when you inhale the general anesthesia, for example, yes, you inhale it, you fall asleep in 1 minute, but when you stop inhaling, you again wake up very, very quickly. So that means the short duration of action. What are the advantages of the injections? Yes, intravenous, subcutaneous, and intramuscular. Absorption is more rapid than with oral administration, and the rate of absorption depends on blood flow to a particular tissue site. Intravenous has more, of course, more absorption, you know that, because it directly goes to blood than Intramuscular has more absorption than subcutaneous. And specifically to intravenous injection, we inject directly into the blood our drug. Rate of infusion can be controlled, yes, and a more accurate prediction of dose is obtained. So what does it mean? It means that if I want to give 20 milligrams of omeprazole to my patient, and I give 20 milligrams directly in the blood, so I'm sure that 20 milligrams are there in the blood. If I give any other route of administration, I'm not sure how much was absorbed. Maybe it is not 20, maybe it's 19 or 18 or maybe even 10. Yes, I'm not sure. So in only IV and also intra-arterial administration, we can be sure that the whole dose was reaching the bloodstream. But also injections has some disadvantages. They are not ideal. The disadvantages and risks of injections are a rapid onset of action, can be sometimes dangerous in overdosing, if overdosing can occur. Yes, really, sometimes if you suddenly overdose, you cannot take this drug back from the blood. Yes, you understand that. Because if you overdose, for example, orally, then you can wash your stomach, yes, make that vomiting, maybe some drug will be removed. But if you give drug directly in the blood, you can do anything. If the drug is administered too fast, heart and respiratory function could collapse. Really, some drugs with strong effects, they can collapse the heart. This is a dangerous complication of some potent drugs. So you should always think, have I to administrate this drug in drops, like how we call it, like IV system, when you have drops which slowly inject the drug in the blood. Okay, drugs insoluble in water or dissolved in oily liquids cannot be given by IV. Of course, everybody understands that you shouldn't give liquid oils in the blood. Yes, because what will be this how we call it, embolia, embola can be. Sterile techniques are necessary to avoid the risk of infection. This is not a very big problem, but it makes difficulties for patients. If patient is at home, if he is not in hospital, it can be difficult for him to make everything in sterile environment. So he can need some help from some medical people with medical education, or maybe a nurse or a doctor. Okay, when the drug is absorbed to the body, we have some different types of transport of the drug. First type, the easiest, is passive diffusion. This is penetration of the substance through the biological membrane along the concentration gradient without energy consumption and without use of transport proteins. What does it mean? That means nothing is used for the drug to go through the membrane. I have membrane, I have my drug outside and less drug inside. So the drug directly goes through the membrane. It can be achieved only if the drug is lipophilic, I already told you, because membrane is made of lipids. Then facilitates diffusion. It is the penetration of substance through the biological membrane along the concentration gradient without energy, but with the help of special carriers, conveyors, special carriers, some special proteins which can take the drug outside and bring that to inside. And active transport is penetration of substance through the biological membrane against concentration gradient with expenditure of energy and help of special carriers. So let's see. This is passive diffusion. Yes, directly through the membrane, nothing is required. And facilitated diffusion is when we have some special protein to bring the drug from there to inside. So this is facilitated. It is facilitated by my special proteins. And active transport requires energy. ATP, you see, requires energy to bring the drug inside, because maybe it is already too much drug here, but I also want to bring more. Yes? So this is why it is active transport. So it needs not only the special protein, but also the ATP energy. Also, we have some endocytosis. Again, sorry for Russian here, but what is it? So here it's inside the cell, this is outside the cell, and it can be phagocytosis or pinocytosis. And in this case, the membrane can capture this particle to bring it inside the cell. If this is a solid substance, this is phagocytosis. If it is liquid, it is the pinocytosis. And also receptor facilitated endocytosis, when receptors capture these special molecules, and only after that the vesicule is made with these captured substances. These all are endocytosis. Of course, you understand that it also requires energy, because this is a difficult process. What happens then? I told you about degradation, the biotransformation in the body. Yes, this is a complex of biochemical reactions which transform drug into more water-soluble metabolites. But why it happens? Because our body wants to excrete water-soluble metabolites of the drug are easier to extract from the excrete from kidneys. But biotransformation can lead to not only to inactivation of the drug, but also sometimes to activation and sometimes even to toxic products. It depends on the chemical nature of this drug. What are the stages of biotransformation? The first is metabolic transformation, which includes oxidation, reduction, or hydrolysis of the molecule. These are all just chemical reactions, yes. And the second stage is conjugation. This is a biochemical reaction because special molecules from our body can bind to the drug. Glucuronide, sulfate, glycine, acetate, glutathione, methyl can bind to the drug. Also, one very important structure in our body which makes some biotransformation is cytochrome P450. This is the enzyme, especially in the liver, but not only. And this is the main enzyme of microsomal oxidation. It may main place of localization is hepatocytes, I already told you, in liver, yes, and biochemical function is oxidation. After all this happened, yes, oxidation, the rest stages, the drug goes for elimination, and the main elimination is in the kidney. In kidney, this is filtration, absorption, and secretion that happens, and then metabolites, which are poorly absorbed in kidneys, are excreted in the urine. But some drugs are not excreted, they come back into circulation. Yes, some drugs have active lipid-soluble metabolites that are reabsorbed into circulation. And they come back to the artery and they don't excrete to the kidney. But not only kidneys can excrete the drugs. Also, we have, for example, lungs for excretion. When we drink a lot of alcohol, we have alcohol breath. Yes, I think everybody knows that. For example, breast milk. Breast milk also can excrete some alcohol or antibiotics or any other drugs which are taken by mother. Also, bile, skin, and salvia can excrete the drugs. So actually, some drugs are found not only in the urine, but all other biological liquids of human body. Thank you for your attention. This was the lecture on general pharmacology, and I'm sure that it will be useful for you for preparation for the topic today. Thank you very much.